Okay, good afternoon. This is the start of the last track, and I would like to introduce Dr. Radinsky, who is the CTO and chairwoman of Diagnostic Robotics, and she is going to talk about how using AI we're going to cut the lines in the emergency room.
Wonderful. So I'll share with you. Hi. So I want to share with you, although I'm the one speaking here, this is joint work of around 60 people for the last 2 to 3 years, jointly led by Professor Moshe Shoam, which is, if you don't know him, is a pretty well-known person in healthcare. He was the founder of Mazor, just acquired by Medtronic for almost $2 billion. And Jonathan. We all started at the Technion actually as a small academic project. I'm pretty sure that you all have noticed the emergency rooms are pretty overcrowded. And we were starting to think about how can we take all of this data accumulated in the Israeli ecosystem and start building systems that can try to automate some of the processes inside the emergency room. So Jonathan was a pilot cadet. He was an Olympic sportsman, got injured. This is how well he knows the emergency rooms. And he started studying medicine, and he actually joined me and Moshe with this amazing small academic project almost 3 years ago. Since then, additional 60 people, very multidisciplinary team of both engineers, data scientists, designers, doctors, economic specialists are joining the same effort. And the effort is the one that you all notice. There's 3 main problems that we all know inside the emergency rooms. One of them you all know, they're completely overcrowded. Today, how long do people wait inside emergency rooms, in your opinion? Too long is a good question, but there's a number behind it. 3.6 hours in Israel, 3 hours on average in the United States. But one of the main problems that we see because of this overcrowding is the fact that eventually it causes a lot of diagnostic errors inside the emergency rooms. It's the 3rd leading cause of death in the United States. Specifically, when somebody is being asked why all of this happens, is the fact that there is a shortage of clinicians of 60 to 90,000 clinicians in the United States alone. Now, the thing is, the population is growing, but it's not growing linearly. So the number of ER visits per 100 people is actually growing. Okay? So the more people we're going to have, the longer we're going to be waiting, and the longer it is per person as well. How long are you asking? So, as I mentioned, till 2030, there's going to be 3.8 billion people without access to primary care. So this 3.6 hours that we're waiting right now in Israel are going to be much, much longer. And you're asking yourself, how long? Let's look at China. In China today, people are waiting 8 hours on average inside emergency rooms. So we visited there, and it turns out that in small villages, people have so much distrust inside the ecosystem that they have planes flying to the large hospitals. They call it sick planes. So all of the people inside the plane are waiting inside the emergency room to actually fly to a large city to wait almost an entire day from the simplest flu to something more sophisticated. So what we started doing, we received access through different ecosystems. So we partnered with the government of Singapore, with the government of Israel, east of the United States, and received access to approximately 72 million visits to emergency rooms and primary care physicians. Additionally, in order to actually understand the clinical knowledge behind the scene, because the entire emergency room procedure, which I'll be sharing in just a few minutes, is a way of a protocol of asking questions, getting answers, and sending it to lab tests. In order to understand these correlations, we got access to around 19 million articles. So combining this input data of EMR data, lab results, EKG, sensor data, time series data for approximately the last 21 years with 19 million articles, we started building a machine learning system that is capable of predicting different things in medicine. Specifically, how urgent this patient is, what is the probability of this person to be hospitalized, and what is the differential diagnosis. So this is how it looks today in Rambam. Rambam, for the international audience here, is the hospital in the north of Israel, is one of the largest ones. Today, before you come inside, today what you do, you come inside, you register, you just wait. So the idea is you have this AI stations waiting inside. There's usually a care navigator in charge of several machines you come inside, you start a clinical process of questions and answers via the machine, where the doctors have a big dashboard seeing exactly the differential diagnosis of each patient, how urgent they are, etc., so they can actually attend to the urgent patients first. So the way it works today, you come inside, the system is asking you, why did you come? You say a chest pain. It's asking you, how long did it happen? Do you feel palpitations? Does it hurt the first time, last time? Did it happen 2 weeks ago, 3 weeks ago? All of this while connected to your medical records, so the history of the patient is also taken into account. The triaging system decides, based on the answers, to which labs to send. For example, if a person comes in and the system predicts that the person has 62% pneumonia, the system might recommend to send to an EKG and X-ray. Once the EKG and X-ray come back, the system changes the differential diagnosis, because it might come back and they see that the chest is clean, so the chances of pneumonia drop to 33%, and the chances of musculoskeletal chest pain just went up. And this process is going iteratively without any doctor in the loop. The doctor comes in only at the end. The doctor oversees this entire process. Every time a task comes back, he sees the new results and knows whether there is an urgent patient inside that needs its attention. Based on these probabilities, they started building different types of workflows. And I'll give you an example. We had a person coming inside a year and a half ago. He would have waited 45 minutes for the nurse on that day. He started using the system on the first stage, and then he reported a pain radiating from his abdomen towards his back. The system immediately calculated the probability that it might be a dissection of the aorta. Immediately, a red flag was put inside one of the doctor dashboard. They immediately pulled him from the emergency room to the operation room. All of this would have taken 45 minutes in the regular workflow. Parts of it is done by rules. There's protocols, but somebody needs to ask those protocols. Some of them are done by a probabilistical system trained on the 72 million visits before that. But everything I was telling you right now is super interesting, right? You might believe or not believe, but what I wanted to actually share with you is why is this so hard and why it didn't work from the first day. So a lot of the things we were doing were taking data coming from emergency rooms and HMOs. And the first thing we wanted to know is which questions we should ask the patients. So we have a team of around 30 doctors. Those 30 doctors wrote different types of questions. They always forgot. You had additional Q&A. What is the protocol? It turns out there is no specific protocol about what to ask you when you come inside the emergency room. It's what you learn from the doctor you learn from. So instead, because we had access to all of these medical summaries, we started a simple NLP process. We started extracting symptoms, and for each one of the symptoms the patient reported, we know the final diagnosis as reported by the doctor after all of the lab tests came back, historically. So behind the scene for each patient, we have all of the symptoms that the patient answers, and additionally, at the end, we have the final diagnosis given after all of the tests. So this way, even if the doctor has some mistake in the way, eventually after all the tests, readmissions, etc., we will know the final diagnosis. We then started building different types of machine learning classifiers, from naive-based to logistic regressions, SVMs, deep learners, everything you can imagine, and just empirically selecting for each complaint which one works the best. So eventually this algorithm knows how to see answers of the patient, the symptoms, and then eventually predicting the diagnosis. They produced even a trial. So this is a trial. They took 30 doctors in Mayo Clinic. They asked them to do the same thing for 5 symptoms. It took them 5 years. Okay? Why this point is not at 100%? Because they disagree among each other. Okay? Now the 2 dotted lines you see here are 2 different algorithms. And what can we learn from this? The system is not as good as 30 doctors in Mayo Clinic, right? So you see they're getting to 98, we're getting to 92, but the main power of this system is not the fact that it's better than doctors. It's the average doctor, right? But it did it on 5,000 different complaints. Well, these doctors, it took them 5 years for 5. But what we then said, how can we take this system from this 92 and get it to a point where it actually correlates with the average plus doctor? So the main problem we started seeing is the fact that many times doctors just write, well, this patient didn't have the symptom. So when you actually look and extract just symptoms that correlate them with diagnosis, you get these simple mistakes. So what we then started doing, we used a system, a deep learner, to identify negation. So we want to identify what is the negation in this free text of the medical summary produced by the doctor. Is the symptom negated or not negated? Sometimes this is very hard because the actual negation is very far in the text. So we first used a trained model coming from different sources, the usual ones. News articles, Wikipedias, etc. Unfortunately, it got too many mistakes, so we started tagging additional medical summaries internally and improving the model over and over and over again. So you can look up at this paper and actually look at the details. But then we noticed that doctors are not writing medical summaries for our machine learning system to actually work. They're writing it for their own sake or for other doctors. So you can see this type of sentences happening a lot. The patient was admitted with hypertension along with accompanying conditions. What is accompanying conditions? Okay, so you need a lot of word knowledge to actually understand what this doctor actually meant. So we call this problem latent entity extraction. So we want to extract this hidden entities that the doctor has in his mind, but they're not written in the text. So what we started doing, we started building a multitask learning system that tries to predict which type of symptoms usually happen together. We actually grouped them by their occurrences in usual medical papers. And then eventually we're trying to predict for each latent entity what is the probability that it was or can be inferred from the text given. This paper was published in Cornell. You can actually look it up. And then the results were not just satisfactory. We're missing lots of symptoms, especially the weird ones. And even training the system took us too long, and it didn't apply well for the medical summaries that we had. Again, 72 million, and now we even got to 22 billion claims, so it got a bit bigger than we expected. We then moved to a bit of a more of a deep learning approach. The idea is you receive possible outputs of symptoms the doctors wanted to say, but they didn't say inside the text. Here we receive the actual medical summary. We put it through an encoded-decoded system that eventually wants to try to predict for each one of the entities what is the probability of this entity to appear. And the reason we're doing this together is because if before we were trying to predict for each entity separately, here the outputs themselves have relations between them. So if a certain output appears, there's a high probability that a different output will also appear. So several symptoms might appear together, and the doctor will decide not to write all of them. So during training, this is what we've done. It turns out that there's certain symptoms that don't appear a lot, some of them do appear a lot. So writing several decoders in different sizes, depending on the type of complaint we're working on, proved itself to be beneficiary. During actual labeling, we actually do random noise here and then sample the entities from here. Everything I was just mentioning right now is actually dealing with different, very unique natural language processing problems inside this specific text. So how well did it work? So we were trying to actually compare to this BERT, the multitask learning approach that were published in Cornell, and we see that this deep learning approach, the more entities are missing, the better the system is. So if for a certain complaint, doctors usually write the entire set of symptoms, then it pretty much doesn't matter which one you use. If you actually want to see where doctors are actually missing lots of symptoms because it's so clear they didn't have time, they have just 1 minute per patient, etc., then using this deep learning approach we call COCA is a much better approach. Everything worked pretty well, but again, this wasn't enough. And we wanted to think about how do we take all of this word knowledge that doctors write in these medical articles and try to enrich this question answering process. And the reason is, if you look at the EMR itself, you can get weird correlations, like psychiatric patients are more likely to suffer from Parkinson's disease. The thing is, this is not exactly correct. The reason is that it is just a correlation, not talking about causation. So we started thinking about the fact about how do we actually understand causality. The main reason is you don't want to ask infinite amount of questions from the patient. You actually want to understand the causal relation between the answers the patient is answering and what the diagnosis should be. So what we then started trying to understand is how do we build health causal graphs. So I'll walk with you through the process. You can actually read the entire paper done by Gali Nordon in 2019. The idea is we have a set of medical articles. From them, we actually, using different NLP techniques, try to extract when a doctor writes inside a medical article, A causes B. It then helps us create a very condensed graph of what A causes B, etc. Now the problem is this graph has tons of problems. Sometimes, my favorite one is, does A cause B? No. This is an amazing title for a paper. Now there's many problems of this sort, and what we then notice is that when these graphs are very condensed, doing inference from these condensed graphs is very hard as well. So we learned that we want to cluster them. So for example, if somebody's coming from a certain complaint, I just want to look at the subgraph related to this specific complaint so I can do this question and answering process. So we started looking at different methods to try, given a new complaint, to identify the subgraph we need to look at. At the end of this process, we then identified that still NLP is awesome, but it still does a lot of mistakes. But we have EMR data. And if there is a causality, there should be a correlation inside the EMR. So if we see that A causes B inside the literature, but we never saw this in any of the HMO data, this might be a wrong causality inference. So I'll show you each one of the steps very slowly. So the first one was pretty much having a text and trying to extract that, for example, celiac disease causes malabsorption, or malabsorption causes anemia, etc., etc. So the way we did this, we have a classifier for each one of those relations, and the system just runs. How did we get this? There's many public data sets to train some of this causality inference. Some of them, again, are not enough, and we had, again, internal labeling done inside the company to actually infer each one of those causality links. As I mentioned, if we have a new disease and want to inference it, I just want to look at the subgraph relevant to it. The problem is that we want to disconnect, there is several disconnected causal facts. Sometimes they write the same word differently, and there's different subgraphs that just need to be reunited. So what we then try to do is try to find a way of measuring a distance between the disease and its surrounding and the causal graph. So what we then do, there is many methods. Some of you are coming maybe from an NLP background, so you know word-to-vec, etc. There's a lot of advances today in graph called not-to-vec, etc. is a way of representing each node inside the graph via a vector. So when I have a new node, what I do then is I do random walks inside this graph. For each one of these walks, I consider this a sentence. This sentence can go through the different autoencoding states and eventually gives us a vector, very similar to how word-to-vec works. Usually in word-to-vec, you look at each word, which words appear next to it. Here you look in which types of path this node will appear. The output of this process is eventually a vector for each one of the nodes. Then eventually, when we have a new disease, I'm just going to look at the subgraph that is relevant for the disease I want to predict. This will allow me, during questioning of the patient, to only focus on the questions and symptoms that are worth asking because they have causal links between them. The last part is actually understanding that, well, this is amazing that we have this causal graph, and even after identifying non-condensed areas in it, I still want to identify if there's correlations inside the EMR supporting this causal relationship. We call this the merged graph. So what we then did, we started analyzing all of these results and trying to identify how we should do the condensed graph mapping using a not-to-vec, concurrence, word-to-vec, etc. Eventually, what we've noticed is that if you only look at text, the best you can get is around 30% accuracy, which is completely not a lot. If you do the merging, you get to almost 50%. If you add all of the negation, the symptom checking we got before, etc., then we get to around 92% accuracy around only the graph for this question and answering process. Amazing, right? It should work in a retrospective way. We started running, the AUCs are super high. But then we started running prospective trials more than a year and a half ago in different hospitals. We start running the prospective trials and we see something amazing. The AUCs are almost 50. In other words, there is no connection between what the patient answers and what eventually the doctor hears. And I'll give you an example, right? The patient, out of all the patients reporting about constant pain, how many times did the doctor actually document a constant pain in the chest? 50%. Let's go with another one. 10%. 20% of the time, okay? The other times he says, well, pain comes and goes. My favorite one is pain disappeared, okay? Let's look at another one. Out of all the patients coming in with chest pain, 21% of the patients said that the pain radiated to the left side. This is inside the emergency room in Rambam and Sheba. How many times did the doctor agree with the patient? No. 5. So what's going on here? Who's not listening? Is the patient not understanding what's going on, or the doctor is not listening? So this is a lot of the problems that we actually had to handle. There's a huge transfer learning approach here between what patients hear and run compared to algorithms run on a corpus which was trained on what doctors heard. And all of this transformation is something that we had to build with time. So I'm going to share with you the prospective trials run on a hospital in Rambam. So eventually we had access to 800,000 ED visits, out of which 30,000 were headache. I'm going to show you the results for headache. The other ones are pretty similar. So what's so special about headache? There's a little bit more females than males. It's more of a younger generation complaint than an older generation complaint. And what we were trying to do is actually predict the right diagnosis. So again, we're doing differential, so it's a ranking problem. So 80% of the time, we get the right diagnosis at the first place. Again, this is not amazing, and the main reason is the fact that just most of the time, 75% of the time, the diagnosis is general headache. It's a nice way of saying that you shouldn't have come here, okay? But then we see that if we look at one of the two first ones, we get into 93%. If we look at the first three, 98% of the time, we get the right diagnosis right. What do we learn from this? We're not going to replace doctors with this specific system. What we can do is start building automation workflows, saying, hey, if one of the scary diagnoses is in the first three, then do an EKG, then do an X-ray. And all of this I'm showing you is only based on question and answering. Once we started getting the EKG and X-rays inside the system, of course, the diagnosis and probabilities are becoming much higher. Now, you're probably thinking that, okay, how well do you actually predict the different lab tests? So, for example, in Rambam, 50% of the people coming in with a headache got a CT. This is a huge number, by the way. So what we see, we can actually mimic the doctor with an area under the curve of around 75. So what do you do with it? Again, 75 is not amazing. We're not going to replace the doctor. We're not going to send them, don't send to a CT. What you can say is, above this line, automatically approve the CT without the doctor. And you can say everything below this line, if the doctor wants to do the CT, and he's not an expert doctor, he should consult with somebody. The same thing with an LP. LP in Hebrew is dikultan. Well, it's very painful, okay? And besides, this is a very dangerous procedure. So here, 10% of the people coming in with a headache got an LP. This is amazing, right? It's a huge number. So everything we can do about saving this, it's sometimes unneeded procedures. What they try to find is the right threshold, and each hospital and provider system is defining a different threshold for themselves. Now, you're probably thinking I'm showing you headache because this is our best results, right? So I'm going to show you back pain as well, okay? Back pain, again, we see that the area under the curve can range between 77 for things like backache unspecified, which is just a nice way of saying, hey, why did you come here? And to more advanced ones like 92, which is neoplasm-related pain, which is much harder to identify during question and answering process. So I just want to show you one example. There's one doctor here, and any additional ones? Do I need a guinea pig? Okay, there's only one doctor here, and she already saw the presentation. So usually what they do is they get a full medical summary. I ask doctors, can you know what happens to the specific patient? And even the simplest cases, sometimes nobody wants to yell it inside the lecture. But what the system is actually helping them understand is not only why it thinks, for example, it's sinusitis, it tells them how much times from a relative probability point of view, how many times more than the average population. So in this case, this person has 40 times higher chances than the general population to have sinusitis. And the reason is because they have a cold and stuffy nose, and it hurts when leaning the head forward. Now, the system is not always getting it right. For example, in this case, the system predicted cluster headache with almost 99 times higher than the average population. But eventually, the person was tested by an ENT, And it was only sinusitis, which was ranked only second, 2 times higher than the average population. And the reason is a lot of those things actually require a physical examination. Now I want to share with you something even more amazing. You probably think it only works for Rambam, Jewish people in the north, right? Maybe it works only in Soroka, right? I want to show you almost the ultimate population, which is so different, and the most interesting thing, it seems interesting about how it works. So we started working with the Singaporean army. It's 19-year-old males from Singapore, usually healthy. So this is for headache. You can see that the distribution of the different diagnoses is very different. Most of them are general headache. In other words, well, you're fine, okay? You see some migraines, sinusitis, see almost no meningitis at all in the data. And then what we started seeing is the fact that if you take the Rambam classifier, so for example, for sinusitis, it's getting to an AUC of 89 on the test set, and you actually apply it on the Singaporean data, you even get better results. And the reason is inside the hospitals, you actually have the lab test and the physical test to validate the result itself. And the most interesting thing, in the 100,000 examples of the Singaporean army that we received, there were almost 5 cases of meningitis. We couldn't even train a machine learning classifier on top of their data. Here, we managed to identify the single case of meningitis that was in the test set. If you look at when we trained on their own data without a transfer learning approach, we see that we're getting AUCs which are much lower, around 70. So this one is very small, around 80. But when applying from an ER hospital to their data, we're seeing much better results. So I started this talk about the fact that, well, 3.8 billion people don't have, or not going to have access to primary care. How is this going to solve this? When they're getting to the emergency room, this is way too late. And the reason is mostly is that 30 to 70% of the people inside the emergency rooms could have been treated from home, or at least from an urgent care center. And the spendings about unneeded emergency room visits is around $200 billion a year in the United States alone. Very similar numbers in shekels here in Israel as well. So we started thinking about how can we take this from home? And this is something we're now going to be launching very soon with the different HMOs here in Israel and with Blue Cross Blue Shield in the United States for 40 million members. Now this is the vision. It's going to be deployed in very simple steps at the beginning. I'll just walk you with one. I have a lower abdominal pain. I don't feel really well. I'll go on my Leumit app, my favorite provider. It's asking me a set of questions. Does it hurt when urinating? Do I have fever? I say yes, yes, yes. Behind the scene, it reaches a 60% chances of UTI. At that point, if it is more than 30%, again, depending on the provider, they're approving me a urine test. By the way, I don't know if you know, but you can actually get a urine test to your home, do the urine test at home. A system will read the result. It's based on a sensor called HealthCare. And then let's say the system is changing the probability of UTI to 90%. Now, depending on the provider, some of the providers are usually having a telemedicine doctor or your own doctor with an SLA of 3 hours to approve you antibiotics, which can be sent to your home as well. Some of them decided specifically for UTI that there is no need for approval from a doctor. Now, this is a very unique scenario, thank you, that doesn't require a doctor. Almost 99.9% of them gonna require a doctor in the procedures. But we do think it can actually double the scalability of the doctors and staff that we have right now. And what we're exciting to now see is whether it's gonna actually work for this 40 million members in the United States and us, 8 million people here in Israel. Thanks so much.
Been an ER doc for many years, and many patients know they can game the system by saying, I've got chest pain, and they have no chest pain at all. Or a young girl wants a pregnancy test. I have abdominal pain. She just wants a pre-pregnancy test. How do those sorts of categories of patients impact your model, and how does the model deal with, it's predictable, I imagine, that people will do that?
Right, so very good question. So it turns out based on the numbers, again, this is research not done by us, but different ones, there's always secondary gain for some of the patients. And if they're gonna trick the system, they can trick, it doesn't matter if they trick an algorithm or they trick a doctor, right? We can still have a person in the loop. It doesn't have to be a doctor. Doctors are not, well, lie detectors, right? We can put somebody else that can be a much better lie detector and just work with them and read with them all of these questions. Today, the number is about secondary gain. For example, for chest pain, they're talking about less than 10%. And what the doctors we've been working with said that they don't want to handle at this point, this 10%. It's more important to increase the flow, identify the most urgent ones, although you're completely right about the secondary gain. But even in the actuarial analysis we're doing, it's not moving the needle too much. Amazing question. So 2 answers. It's not good for all of the patients, right? Let's get to even 30% of them, the ones which are eager about technology, etc. Patients they quite know what they have. More than 91% of the time, they do know their main complaints. For example, they know the chest hurts and not the back, for example, right? They can get confused, for example, with headache and dizziness. This is something that usually the system is supposed to help them with. Eventually, even in the hospital, in very urgent situation, there's a care navigator. There's a person next to all of these machines. They're not doctors. In Hebrew, they're called doctor helper. It's usually paramedics, etc. that are supposed to support you mentally if you need any help. I think at the first step, it's going to be a lot of the decision support. The system is not something that replaces the doctor and anyone in the middle. It's eventually a decision support that if it identifies a red flag, it says, okay, there's no need for you to wait for the doctor. Just go to the emergency room. But if not, it's going to try to navigate you to the correct location to reduce the loads from different hospitals. And yet to say, again, we're in prospective trials. Okay, so we still see some fluctuations in some complaints. Other ones are easier. For example, chest pain is a bit easier. Dizziness is the most horrible complaint, for example, right? It could be everything. It's such an ambiguous term. A lot of learning, right? Yeah.
Last question. How does the FDA and the regulatory bodies look at this?
So our system has received an FDA exemption. Okay, and for other types of the features, we're actually doing additional FDA in a 510K non-de novo case. So parts of the features have already been approved. Some of them are not going to be regulated. And the third parts are still in prospective trials. So we continuously develop the system all the time. So we're running in prospective trials in Maimonides and Mayo Clinic in the States.
We ran out of time, unfortunately. So thank you very much.